Hello everyone, this is Dr. Prem. Today we are going to see another approach, superior trunk block, and this is the ergonomics of this block, and this is the position, and we are going to do this block for a patient with clavicular fracture. So you have to take a linear probe, high frequency linear probe, and start scanning from the midline, especially at cricoid from the cricoid cartilage, and you can see the trachea and sternocleidomastoid carotid pulsating. You can see the C5 and C6 nerve root coming out, and you can see the scalenus anticus and the scalenus medius, and you can see the transverse cervical artery in between, which is coming in between the uh, brachial plexus and the scalenus medius. So it is always better to put a Doppler in the scalenus, in the region of the scalenus medius muscle, and locate the transverse cervical artery. This could be a reason for local anesthetic toxicity, and we may puncture that also. So putting a Doppler is very essential, and we have to find a region caudal to the transverse cervical artery to avoid the puncture of that artery. Again, you can see how it is being scanned, and this is the structures which is being named. You can see the upper trunk, middle trunk, and the lower trunk, scalenus anticus and the scalenus medius, and the investing layer of the deep cervical fascia. So once the region is scanned, always make sure that you locate the dorsal scapular nerve and the long thoracic nerve of bell, which will be usually inside the scalenus medius muscle, and it will be always better to avoid injury of the nerves while needling. So once you locate the nerve and avoid the dorsal scapular or nerve and transverse cervical artery, you can always choose a 22 gauge echogenic needle or stimuplex needle, and the trajectory is to avoid going into the scalenus medius muscle to avoid the transverse cervical artery and the dorsal scapular nerve and the long thoracic nerve belt. So once you have a trajectory, so the trajectory is between the needle has to pass between the uh, anterior portion of the scalenus medius and the investing layer of the deep cervical fascia, so that you can avoid the structures which I indicated. So here you will be seeing the needle coming through the deep investing layer of the deep cervical fascia and anterior to the scalenus medius. You can see three structures there in the upper trunk. In that, the lateralmost structure is the suprascapular nerve, and you can see another two structure there. Yeah, you can see the three structures there. That's the superior trunk. You can see the needle stimulating that, and the authors who demonstrated this technique uh, actually published it in a way they suggested a volume of local anesthetic of 10 ml in the postero-inferior region. You can see the needle going into the postero-inferior region of the superior trunk, and they suggested a volume of 5 ml over the anterosuperior region. So I also recommend the same volume to be given for the superior trunk, because when we reduce the volume, it reduces the incidence of phrenic nerve being blocked, and we can reduce the incidence of hemidiaphragmatic paresis. So why is this block being given? It's always a good big at least 2 to 3 years before, like for most of the shoulder arthroscopies and clavicular fractures, it was standard by giving an interscalene blockade. But because of the higher incidence of phrenic nerve blockade and hemidiaphragmatic paresis, alternative approaches has been suggested and has been done. And one among that is this superior trunk block, where they have found an incidence of phrenic nerve blockade of around 5 to 6 percentage, which is very significant when compared with interscalene blockade, which is around 90 percentage. So it is a very reasonable alternative for interscalene block, provided you give this 10 to 15 ml of local anesthetic. And it is always a big challenge to take the needle in the anterosuperior region, because the investing layer of deep cervical fascia will be very adherent to the superior trunk in the anterosuperior region. So make sure that you're not injuring the nerves, or injuring the trunk, especially in the antero-superior region. You can see again how it is a challenge in this video how to take the needle in the antero-superior region of the upper trunk. Yes. Now you can see that, and we have deposited around 3 to 5 ml of local anesthetic there. Generally, we prefer giving zero point 0.5 or 0.75 percentage of ropivacaine along with an additive like dexmedetomidine of 20 mics or dexamethasone of 4 milligram. This will give very good analgesia, post-op analgesia of around 8 to 10 hours. And once this is done, and if you require supraclavicular nerve blockade, we can always do that once upper trunk is being blocked. And according to anatomical studies which has been published related to the upper trunk, they have found that the lateralmost structure in the superior trunk is the suprascapular nerve, and the anterior division and the posterior division. That is the in the divisions, the biggest one is the anterior division, which you can, this picture is taken from another patient. You can see three structures there, which is being zoomed there. The lateral most is the suprascapular nerve. The anterior and the superior most is the anterior division, and the bigger one, which you see, is the posterior division there. So we have just zoomed it to give a very good idea of the superior trunk. And in the next, and as you finish depositing the local anesthetic, locate the supraclavicular nerves, and if you, in case you require it for clavicular surgeries like clavicular fracture or shoulder arthroscopy, which would involve also the supraclavicular nerves, always deposit around 3 to 5 ml of local anesthetic in the supraclavicular region so that the superficial cervical plexus can be blocked, and this would give a fantastic surgical anesthesia for the patient. So this is about this block, and it's a very reasonable and a good alternative compared with the interscalene block. Thank you very much for listening.